Hi, my name is Andrea Herbert MD, and I'm here to talk about airway and intubation. Okay, welcome to intubation. So today we're going to go through my way of doing a step-by-step orotracheal intubation. So this is oral intubation. We're not going to do nasal. We're going to talk about the step-by-step, checking the equipment, checking that everything you have is prepared. I want to go over the dexterity of how I think the best way to hold and position your hands and doing manual dexterity, because oral intubation, this is a really eye-hand motor activity. So I'm going to tell you how I like to intubate, how I've taught medics over the years, and it's generally been well received and it works for me. So there you have it. So first thing is you're checking your equipment. So your equipment is your safety. So if you've checked your equipment, and preparation is key. So I say prepare to succeed. So basically what I'd like to do is the same way every time. Intubation is a life-saving maneuver. Orally intubating somebody is going to make a difference in saving their life if you do it correctly. What gives me comfort in a very stressful situation is to know that my equipment is in the same place every time. I've checked it the same way every time. I grab the same equipment every time. You're going to find out what size blade you like and what kind of blade you like. So I'm just going to go over some basic pearls and words of wisdom for doing an intubation. So here's your airway roll. You want to have different sizes of ET tubes available, different stylets available. They're all flexible stylets, and we'll talk about that a little bit more. You have a handle and different choices of blades. There's curved blades, and then there's straight blades. So we're going to talk about it a little bit more in the video. So a straight blade is also called a what? Miller. Good. And a curved blade is also called a Mac or Macintosh. Okay. So I'm not here, I have no investment in either one. You need to try and practice on both. Definitely on the mannequins, practice with both. It'd be ideal if you can do intubations on live patients with both. I learned very early on that a curved Mac 4 is my go-to. And you'll hear from Ryan Wyatt, and I believe that's his as well too. And I really admire him tremendously, and he's an excellent intubator. So a lot of us in emergency medicine really like the 8. The 8. Remember I said an 8 ET tube is for a man. So a curved 4 Mac blade. And what do you see that's similar about the Mac that may be why it's ideal for intubating? Looks like a tongue, right? So perfect. So it follows the shape of the tongue, okay? It's really good for getting a big tongue out of the way. Now, a straight blade or a Miller definitely has its advantages too. I will tell you this, most anesthesiologists, a Miller, a big Miller, is their go-to blade in a difficult airway. When they come to the emergency department, they give me a big Miller, okay? So they like that because they really like to just yank the entire structures, the tongue, everything down to larynx out of their way, and a long straight Miller can really lift everything up and make the cords appear. It doesn't have the advantage of curving along the structure of the tongue, so to speak, but it does lift everything. Sorry. Oh, you're a doctor. You're allowed to have so just so you know. So practice with both. I like a curve 4 because I can get just about anybody intubated with a curve 4 Mac blade. Okay, a smaller mouth, I'll go for a 3. You can see the size difference. Okay. So when I'm checking my equipment, so I said you have ET tubes ready, you have stylets ready, you have a handle, okay? The way you know the handle is working, and the blade is you connect them, okay? You want to see your light, that it's what? Light is white, bright, tight connection, okay? Don't pinch your fingers here, okay? Wear gloves when you're doing this, okay? And make sure you leave the light on long enough. If you're in a dark area or whatever, make sure that, or I should say if it's bright, it's harder to see if the light is bright, but really make sure the light stays on. Sometimes the light will blink in and out, and then you have to check to see and get another blade And if that doesn't work, then maybe it's the handle's fault. So you have to see if it's a blade problem or a battery problem in the handle. Okay, so you check, and this is fine. So this light's staying on. So I'm good to go. So you never do this. So you've checked your light and you feel like it stayed on bright, tight, white, long enough. You never do this. Okay, I don't care if you're just ready to intubate right now. You don't, that's poor technique. Okay, you close it. Okay, you don't leave the light on. Okay, because that's wasteful. And if it turns out to be a very difficult intubation and you're in there a long time, then you've now limited, if that light stays on for like a minute or two, you've now limited the lifespan of that bulb during your intubation. Because the worst thing is to lose your light right when you're searching for the cords, especially in a difficult intubation. So I check that I have the right blade, the right handle, the light is good, I have a good connection, I put it down. I told you I use for all men, and here I have a male mannequin, I'm going to give him an 8, okay? So if you're handed an ET tube like this, you can choose how you like to curve it. I like a gentle hockey stick, okay? That works really well for me. I think that is too angulated and too severe. And Elias, speak up anytime. Is this what you like, a curved hockey? Thank you. You must have been trained well. Okay, so I like, some people will go like straight angle out like this, a 90 degree. I think that's very pokey and I don't like that. So I like to just have it like curved so it's not in my way, and I like a right angle like that. Okay, so it's not going anywhere. Okay, you'll go over in the video at least 1 centimeter to 1.5 centimeters, the tip of the stylet from the eyelid or the end of the ET tube. Okay, so if I do a good 90 degree angle, there's no way that this is going to migrate through the tip of the ET tube and potentially hurt the soft tissue of their distal trachea. Okay, so then there's the balloon. So I've looked at my ET tube. I like my hockey stick configuration. I like my malleable stylet. It's not going anywhere. Then I check my balloon. So if the cuff is already deflated, you get a 10 cc syringe and you get a nice tight fit and you blow it up. Now you'll see that that didn't make this tight all the way, so you have to get some more air into it and blow it up until it's taut, come out. Some ET tubes, even though they're brand new, they may have a little tiny microscopic leak in the cuff. It's called a cuff leak. So what you want to do is not just blow it up and then deflate it and say, oh, it looked good. It's like blowing up a balloon. Oh, it went all the way up and I'll just take it down now. You want to feel it. And you basically gently pinch, and there should not be a, like feeling a balloon, where you feel a balloon and you feel like some air is coming out of it. So it should stay taut like it is here. So as such, this is perfect, okay? You're not going to really hear the leak. You're going to maybe feel it and it gets softer and not as tight, and then that means there's a microscopic leak, okay? So I'm comfortable with the amount of air that there's not a leak, and then I get my syringe decompressed, and take all the air out, okay? And like such. So you get all the air out, then fill your 10 cc all the way. So it's a stressful situation. You want to have everything ready. You don't want to have to, oh shoot, I forgot to have my syringe filled up with air. So it's like one step if you're ready to intubate and you realized you have a decompressed syringe attached to your ET tube. Then that's one step. Now you're stressed out and you're disconnecting, and so have everything ready. Or if your assistant's handing it to you, they should hand it to you as such, okay? Ready to inflate and go. To lube or not to lube, okay? So if you're going to lubricate the cuff, okay, I would recommend doing that in a patient that is dry-mouthed. Who do we have? What population do we have? Significant percentage of the year in southern Arizona. Dehydrated, right? Dehydrated patients, whether it's border crossers, dehydrated patients, we have quite a bit, okay? Their mouths are going to be dry as dry can be. I would recommend you lubricating. When you lubricate the end of an ET tube, you are not lubricating down here at the tip, okay? That's not where it needs to be. It's lubricating the cuff. Very small amount of sterile lubricant, and you just coat it lightly. It should not be glopping. It should not be dripping. It should not be big squirts of it on there, because where is that lubricant going to go? Where is that Surgilube going to go? It's going to go in the lungs, okay, and that's not appropriate, okay? So it's basically just a glistening layer so that the ET tube does not get stuck on the tongue or the soft tissue as it's migrating past the tongue, going to the cords, promised land where it wants to be. Okay, So you're going to have your BVM. This is something you're doing before you're ready to intubate. So patient should already be on non-rebreather and then put on a non-rebreather, or you go ahead and start bagging the patient, okay, depending on what the situation is. So I don't have a BVM, but you're doing good seal, good BVM respirations. So for your equipment, if you suspect that there might be a foreign body, you need to have McGill forceps available. Certainly as somebody that went into sudden respiratory distress, particularly a child that was awake and playing and all of a sudden is unconscious or in respiratory distress but not unconscious yet, you better be thinking of an acute foreign body obstruction, a toy, a piece of food, whatever. So have McGills ready in any kid with respiratory distress. It's critical. Also, if you look at a patient and they are dentally challenged, they have teeth that are loose that you think may be knocked out, I would have McGills ready, okay? So you have that ready in case a tooth accidentally gets dislodged. Okay, so as regarding, that was preparation. So stage 1 is preparation. So I've prepared, obviously suction is going to be hooked up either to a suction, portable suction, or for us in the emergency department, we have wall suction. I like to have everything on my right. So I have suction on my right. I have my equipment on the right that I grab for. Okay, the monitor can obviously be on either side. If I have a respiratory therapist, I'll usually have them on whether side is less crowded and such. But I have always had the suction on my right-hand side. So if I'm intubating in a stressful environment, on the floor, on a bed, on the ground, wherever, in the cafeteria, that I always know that if I had a portable suction, they would put it on the right-hand side, and that's where I'm used to having it. So no matter what stress I'm in, I know where my equipment is. So have everything ready. So I'm going to intubate him with a Curve 4 Mac blade and my 80 ET tube right here. So I have everything ready. So when you're ready, and I'm going to do it without the mannequin first so you can see my techniques. I want you, if you're standing and doing your first intubation in the emergency department, or if you're in the field on the ground with the patient, I want you to think that their head is here and you're standing at the head, and think that you want your angle of how you're holding your hand on the blade, your hand on the handle, that you want this to be in a 45-degree direction away into the world, okay? Your world could be in the emergency department in one of our ER rooms. Your world could be in the back of a truck. Your world could be in the bedroom of the patient's house when they're found on the ground next to the bed, unconscious, unresponsive. But I want you to think 45-degree direction of your thumb is part of the handle, and it's going 45-degree direction away from you. Because if you do that, you're going to find the cords, and you're not going to rock back and injure the teeth. And it's not so much that I don't want teeth getting injured. It's the fact that if you're injuring the teeth, that means you're rocking back and you're not finding the cords. So it's improper technique and not getting you where you need to be, and the teeth are the victims or the byproduct of you not getting where you need to be, okay? So when you're ready, when you have everything ready, it is best to try to do intubation with both hands, okay? In the beginning, you might be stressed and you might want to manipulate the head and have somebody hand you the ET tube. I think that's fine, okay? If you're intubating with me, I will definitely hand you the ET tube. I will definitely help you, okay? So some people, it takes a while before they're ready to manipulate the head, open up the mouth, and do all that while they're holding the ET tube at the same time. And I get that. That's totally fine. Okay, so when you have the head, obviously we talked about before, you're going to look at what makes a difficult anatomy for the airway. You're going to do what you can do to try to open the airway and improve your chances of success, okay? So if it's a non-trauma patient, you're going to do what to their head and their jaw? You're going to do head tilt, chin lift, okay? And you're going to find that especially in a patient that's decreased level of consciousness or certainly unconscious, where you pull their jaw, they're really going to stay that way, okay? So, so you pull out their jaw as much as they can. And then I like scissor opening, of course, with gloves, okay? So anytime you're touching somebody's mouth, you're obviously wearing gloves, and you have to be careful if you're not comfortable touching the inside of a patient's teeth. But a scissor opening really does help open their mouth, okay? So scissor opening, you're crossing your fingers, and it's really something you kind of have to see, or you can do it that way, but you really get more bang by just opening with scissors, or you can actually just pull down their jaw. And like I said, generally it will stay that way, okay? You're first gonna, of course, remove their dentures. Anything that comes out easily, you're never gonna struggle and try to rip out a bridge or anything like that because you think you have to get everything out before you orally intubate. If it comes easily, you take it out. If it does not, leave it in, okay? And be very careful. Some of these will cost like thousands of dollars, so you do not want to hurt their bridge. So you've looked and you've opened their mouth, you've suctioned them as appropriately, not aggressively, but suctioned so that you have a nice, clean, dry, pristine mouth to go into, okay? Recognizing if they have a big tongue, okay? So the technique is this. So when you're ready to go in, that's when you turn your light on, okay? You're ready to go in. The head is here. Everybody does it the same way. It's uniform, that you hold the laryngoscope with your left hand, the tube with the right hand, whether you're right-handed or left-handed. Do not hold like this, okay? You've lost your dexterity if you're holding too much on the blade. Definitely don't do this, and I see a lot of people do this in the beginning. They think their whole hand needs to be on the handle. It's really right there in the middle. This is like the crotch of the laryngoscope blade and handle. I like to have my hands right there, and I make my thumb part of the handle. So this is all one unit, and this is so helpful if you're intubating in the back of the truck without me even being in the back of the truck. I know this is the way to do it, because if the truck is moving, you're going fast, you're going code 3. If you are moving, your whole hand and the blade moves as a unit. If you're like this, you're going to knock it inside their mouth and damage teeth and damage the mouth, because you're jerking with your wrist and your hand is causing damage inside because you don't have good control over the blade inside the mouth. So best control is if somebody knocks me, very little movement, because I don't have a vice grip, but I have a secure grip because I'm gripping at the union of the handle and the blade. Does that make sense? Okay, so think of it this way, that you are, as a unit, you are holding it at the crotch of the blade and handle, nice and secure, and when you go into the mouth, after you've done your scissor opening, mouth should stay open, you open the right corner of the mouth and you sweep to the middle. Almost always, every paramedic on their first attempt to intubate goes straight into the mouth, okay? They're excited, they're stressed, it's adrenaline situation, and they think, blade needs to go into the tongue, okay? But actually what's gonna happen? The tongue's gonna flop right into your view. It's gonna flop from the right or to the left, right in your view, and block your view of the cords. So you have to start in the right corner of the mouth, and this is the same with the Miller as well. You need to do it with the Miller as well. Start in the right corner of the mouth and sweep to the middle, and remind yourself that it's a 45-degree direction away, okay? So there should never be any rocking back of your wrist. If you do that, you're gonna hear the click on the mannequin. You're gonna hear you're hitting the teeth in the field. I'm gonna tell you, I'm going to be looking right in the mouth and say, on the teeth, you're on the teeth, you're on, get off the teeth, get off the teeth, because you're looking for the cords. Whoever your supervisor is seeing where you are oriented in the mouth, okay? And you have to be mindful of where you are in the mouth. On babies and toddlers, they won't have teeth. So when you rock back, you're going to injure what? Their gums, and you can cut and tear their gums, okay? So there's never rocking back of the wrist. You keep your forearm and your all the way through your wrist is as a unit. Keep it locked. Doesn't mean you're like in a vice grip, but you really keep it at a 45-degree angle, and you don't have to have strong forearm strength. As you can see, I don't have well-developed forearm strength, but I'm a really good intubator because I know not to do this, and I know to keep this all solid as one unit. Question?
So why do you always hold the blade in the left hand regardless of dominance?
It's just, it's a standard that's just accepted across emergency medicine and anesthesia. So also, good point, that do you see here, you asked the question, the laryngoscope blade is so that, do you see this? So that the laryngoscope blade is structured so that the ET tube is sliding down the middle. So it has to approach from the right to go in as such. So it's the way the laryngoscope blades are designated as well. So that's really the main reason. So by conformity is why it's that way. So right corner of the mouth, okay? So the blade right corner of the mouth, you almost always have to go in a little bit further. and you are going to do motions that are going further down, not rocking back, okay, and never jabbing, okay? And it's a little easier to show on a mannequin than my hand suspended in midair. The key thing is that the ET tube follows what you just did with the laryngoscope blade. Corner of the mouth and advance it. If you go straight in like this, you've now blocked your hard-fought view of the cords. So again, corner of the right side of the mouth, sweep it right into view of the cords. Do not advance the ET tube unless you see the cords. You might not see all of the view of the cords. If you see limited, you're going to see the posterior, okay? Because the difficult airways are more anterior. And that's when you have to rely on somebody giving you more crike pressure if you don't see a full view of the cords. So you go in, and you never, ever, ever take your view off the cords. So you don't need to talk to the driver. You don't need to talk to somebody and say, hey, you have suction ready for me, right? Oh, crap, I just lost my view of the cords. Okay, or say you drop this. Oh, crap, I just lost my view of the cords. Somebody's there to help you. Don't look for the suction. That's why I see people make mistakes. They go looking for suction, they drop their ET tube, or they didn't want to hold it. They wanted to open the mouth a little bit more. I can't find it. Oh, here it is. Okay. Or be a good assistant. I've had so many people over the years hand me an ET tube like this. So don't do that. Hand it to them, and their hand is out like this, right in like that. Go. So hand it to them the right way, okay? Everybody knows, hand it to me the right way. Hand me a McGill the right way. I don't need to look away if you hand it to me the right way. So you go in, and you never take your eyes off the cords. No matter the ambulance is moving, you don't look away. And it is uncomfortable, okay? If you can't get the intubation right away, you still have to keep your forearm, wrist, and hand in a unit locked and loaded like that. You just can't, I'm getting tired and want to relax your wrist. You can't do that or you will not find the cords and you'll hurt their mouth or the teeth. So you put it in, and hopefully you have an assistant, okay, that is going to simultaneously take the stylet out. You can back out, and that's another mistake I see. You need to back out the laryngoscope blade in the same angle you went in. So you went in nice and gently. You started at the right and swept to the middle. You back it out gently. You don't have to back it out to the right, but some people just pull it out, and they knock the teeth out on the way out. That's not right. So you back it out and come out gently, okay? Because everybody just wants to know if the tube's in the cords. Oh, I got to see the end-tidal CO2. Oh, just come out real quickly, and they don't think, and they're hurting the patient. So you take it out gently. You're securing, this is hard obviously to do all by myself, but you have the ET tube in, and somebody's taking the stylet out, holding the ET tube in place. This one's really rigid. And at the same time, inflating the cuff. You might need to do it twice and inflate some more air in the cuff. And end-tidal CO2 should immediately be available. Easy cap, really nice and fast. What's the color change mean? What's good, what's bad? Gold is good, purple poor. Okay, so yellow or gold is good. How many breaths do you need to have reliable, good color change? How many? At least 3 to 5 breaths. It really should be at least 5. Okay, the more the better, in other words. Okay, so what was I also going to say? So securing in the field, you're going to have marketed tube securing devices. In the ER, we have respiratory therapy do it with taping the tube, and you can watch them do that. So means of confirming that you are intubating the patient correctly, that there's good ET tube placement in the trachea, not in the esophagus. What's the number one most accurate way that you can confirm your ET tube is in the trachea? Capnography. Okay, if you don't have a capnographer, easy cap is just fine too. Okay, capnography is better because it's measured electronic data rather than an easy cap. Easy caps can be old. They could have malfunctioning from the manufacturer. The chemical could be old or desiccated and not change color. If you think you did an excellent intubation and you saw the ET tube go through the cords and your easy cap is reading purple, I would suggest you get another easy cap. Okay, break up another bag, it's fine. in general, I'm going to tell you this. Do not take out an ET tube that you witnessed it go through the cords and you did not have any suspicion it was dislodged. You can put a tube through the cords and then all of a sudden your ambulance takes a big turn and you hadn't had it secured yet and your hand pulled back and you pulled the ET tube back. Or unfortunately, I see the medics when they're transferring the patient from the ambulance gurney to our stretcher in the emergency department, that tubes get dislodged then, okay? They're like, who's got the tube? Oh, I've got the tube. And somebody grabs the tube as the patient's being transported over to the bed. And all of a sudden, then the tube's like hanging out this much. And I'm like, oh my God, nobody secured the tube, okay? So it's patient movement or your hand moving when you reached for something. You had a hand on the ET tube, but you reached for something and you didn't realize that part of your body stretched when you reached for something in the truck. And so that's how tubes, it's not meant to be. It wasn't intentional most of the time, but it happens that tubes get dislodged. And they maybe just get dislodged where the balloon goes just right above the cords, but or it goes higher up in the oral pharynx, and that's not where we want it to be, okay? So we want the balloon past the cords, all right? So fogging of the ET tube is good to note and important medically legally that you see fogging of the ET tube, okay? Breath sounds bilaterally and equally over both lung fields you need to document. No breath sounds heard where? Over the stomach or epigastrium, right? Okay? Those are all important, but the most accurate medical legal definition of a secured endotracheal tube is end-tidal CO2 capnography, better than easy cap, okay?
Quick question. So you talked about the order of, you get it in, you pass the cords, and then you secure.
Yes.
Can you touch on for them when they let go of the tube?
Right. So it's hard with me by myself, but it's kind of all. Why don't you come up here with me? So, so when you are inflating, there's three things that need to happen kind of at once, because if you have help, you can really do it all at once. So you've got the blade in, you've got the ET tube through the cords. You can have, if you're by yourself, a lot of people hold two, and Ryan will show you some techniques because he's by himself, obviously, a lot in the helicopter, so that you blow it up and then you get rid of that and you can hold them both together. So you definitely need the balloon up. Okay, you're not gonna be able to feel it when it's in, but you need the balloon up, and you do not take the stylet out until the balloon is up all the way. So always think, I see the cords, I blow up the balloon, and then the rest kind of happens at the same time, that the stylet comes out, and you want to hold that like that. You want to hold this stylet. I mean the right here, like that. Yes, yeah. Ma'am. So I'm in, and the ET tube is in, and I blew up the balloon. So coming out and taking the stylet out, it's pretty much at the same time. I certainly usually come out first because it's so crowded in there and there's so many hands in there. So it helps to get the laryngoscope handle out first. So I come out, I close this off, and then usually, like I said, I have a ton of help, but somebody holds the ET tube and takes the stylet out, okay? So that actually kind of can happen simultaneously. But what can't happen, this has to go first, okay? So if you think about it, if you're pulling out a stylet out of an ET tube that you don't have the balloon up, what can happen? You pull the tube out on top of the cords, okay? And then you realize it, then you blow up the balloon, and then the balloon might be above the cords or at the level of cords, and it'll hurt the cords if you blow up in the. So just be gentle getting the stylet out. It usually comes out pretty readily. And another trick of the trade is when you're holding an ET tube, and I'll just have you be ready for my assistant, when you help me with the mannequin here, that it is very important to watch where your hands are on the patient. You need to be respectful, and you need to not hurt the patient. You don't mean to, but I don't want to see any of this. So when you're getting ready to intubate the patient, I don't want to see any of this. Like, okay, you ready? Everything ready? And you're just, like, this is not a table, okay? Their faces are not, and you'd be surprised, okay? Their face is not a table. It's not a landing place for your hands or your tools or your instruments and stuff like that. So what you can do is you can have your hands around their face and definitely be ready, okay? And let me get my hockey stick back again. We'll do it on the main mannequin here. And so you can definitely be ready. So I've been bagging, the BVM comes off. I'm not a trauma patient here, so I'm going to really try to hold the head down. And I think I'm going to have to actually have you hold it. Devin said you have to hold that. So I have really good head position. I'm ready to go. I've got all my equipment over here. I've like everything I have over here. So I do my scissor opening with my hands. And I see medics in the field that they'll tell me they'll do this or whatever. I think that's okay. I just don't want, like, hey, when are we going to intubate? Elbows up on top of their eyes or on their face or whatnot. So it's scissor opening, okay, inspecting the mouth, do a last minute suction, 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 again, so you have a dry, pristine field. So steps are scissor opening, light on, right corner of the mouth, sweep to the middle, nice grip on the crotch of the handle. My thumb is part of the blade. I might need to go like this a little bit, and I look, and it's totally fine to have your forehead on their face like this, because it's really, as long as you're not directing pressure to their eyes. So there we go. So corner of the mouth, midline, and it's in. So I say to my assistant, balloon up, coming out, gently. I'd get the light off. And this is what I want to teach you. Do not hold the ET tube up high here, because all of a sudden your driver comes to a complete stop, and you go forward and you pull the ET tube out, or you fall backwards and you pull the ET tube out. Even though the balloon is up, let me just tell you, that balloon is not much of an anchor, okay? It's going to go wherever that hand is that's holding the ET tube. Trust me on this, okay? So you will have success about not dislodging a tube if you keep your hands pinched on the ET tube at the level of their mouth. And it's perfectly fine to have your hands resting like this. So a lot of medics, a lot of doctors, a lot of anesthesia, they'll rest their hands like this the whole time they're talking. They'll intubate and they'll talk to the surgeon. Their hands are like this the whole time. So pinch on the face is fine, but just watch your hands are not on their eyes or on their nose, that kind of thing. So pinch, and then you ask your assistant, can you get the stylet out, please? Okay. See, now this one's really stuck. I need two hands on this one. It's not going to be like that in the real life, okay? But you got to watch what you're doing, and people sometimes really get very lax about holding the ET tube, and it's a shame when it gets dislodged because you just did all that work, okay? So then you should immediately have the easy cap already hooked to a BVM, so it is seamless that you have hooked this on, and this should be attached to the BVM. So you put it on, and how many breaths? At least 3 to 5, okay? And you want to see fogging of the ET tube. You want to see chest wall rise and fall equally. No breath sounds over the stomach or epigastrium. You want to see yellow color change. And you want to inspect to make sure you didn't hurt the patient, okay? I didn't click the teeth. You didn't hear any clicking, right? So your assistant can also be looking to make sure, I don't know if you looked to see how far away I was from the teeth, but I was not anywhere near the teeth.
You did great.
Glad I passed. So look to see, because sometimes, unfortunately, I have hit the teeth, okay? I've hit the teeth in patients I have very small mouth opening. And it's a critical situation. And they don't need to be criked just because they have a small mouth. It's just you have to, I just have not a lot of movement in the mouth, and I just have to make sure I get it, or else I have to call anesthesia or do it. Glide scope actually helps reduce that problem because you don't need a lot of mouth opening with the glide scope. So really try to keep hands down low, okay? No jerking, jabbing. So I don't want to see any of this. I can't see the cords. I can't see, and you'll be surprised that it's not really that rough, but I do see kind of jabbing, all right? So when you go in, you don't see it. Well, I guess I have to take this out. Can you take the blue ear out? So if you don't find it, you go in there, and you almost don't ever find it. Let me just get this out. Almost always your first attempt, like this first attempt, I'm at the base of the cords, and then I go a little bit further in, okay? So migrate it down and 45-degree angle away, and think I need to go deeper and more interior, but almost always crike pressure will help you find the cords. So RT or your assistant in the truck say, I need more crike pressure, okay? And sometimes even they call it burp. So burp actually works really well. It's backward, upward, rightward, posterior, or whatever. So just putting a little upward pressure can make the cords pop into view. So anesthesia likes the burp. So anyway, and then you find the cords, okay? Suction when you need to. Don't think you can only suction before or after. There's plenty of times I'm in there and have a view and then I lose it because of pulmonary edema fluid or vomit. So suction, but again, never take your eyes off the cord. Suction, okay, tube, okay? So don't take your eyes off. Suction if you need to, if you're losing your view. Somebody tells you the sats are dropping, get out, okay? You cannot let your ego get in the way. It's very frustrating, especially you think, oh, the doc's only gonna let me have one chance. And we say, the sats are 90. Okay, and I tell you, keep going. And then I say, the sats are 84. Okay, you need to come out. You need to come out, okay? When the sats are dropping, patient's not doing well, it's taking too long to intubate, or the patient's deteriorating, or both, okay? So if somebody tells you the sats are dropping or they're developing a new arrhythmia, you need to be mindful about that. You need to park your ego, and you need to get out and let somebody more experienced do it, okay? Questions?
Do you have any recommendations for when they verbalize as they're doing, what they're seeing?
I think that's fine. For me, usually it's, what do you see? What do you see? Do you see the cords? Do you see the cords? Do you see the cords? Because I think it's really, it's vomit, or it's blood, or it's fluid, or it's foreign body, or pulmonary edema fluid, that there's something above, or they just usually just don't see the cords right away. And a lot of it is because a lot of patients have to have their head really manipulated good. And we have a trick that anesthesia and ER doctors do is we roll up a towel and put it between their shoulder blades, and that actually makes their cords pop out. So we'll do some tricks to make their cords come out. So when I can't see the cords, there's things that we do in the ER. So I need to know if you can't find the cords, because maybe I can't either. Maybe I think it's an easy intubation, you get in there and you can't find the cords, and then I go in there and I look and I'm like, crap, I can't find the cords either. Okay, let's bag them up, let's roll them over, let's put a towel between their shoulder blades, and a lot of times that helps, okay? This is for doing a direct laryngoscopy. Like I said, the glide scope is really making this almost obsolete, okay? Because the glide scope really finds the cords for you. The only time the glide scope lets you down, difficult airways, bloody, fluid-filled airways, because you just can't, because you're depending on a video. So if your view is blocked by fluids coming up, you have to suction as fast as you can see on that video. It's often better to be actually in there yourself doing a direct laryngoscopy when there's a fluid-filled field, shall we say. Most patients are going to be between 20 to 24 centimeters, okay? So that's really important, and I'm sorry I passed by that. So you want to say how many, you want to, for documentation purposes, what size tube and where the tube is at the teeth or at the gums or at the lips. You can make a choice. If they have teeth, we generally, by tradition, say 20 centimeters at the teeth with an 8.0 ET tube, no complications, okay? Or if they don't have teeth, then you say at the gums or at the lips. But teeth and gums are a little bit more accurate because the lips obviously kind of move, you know what I'm saying? So yeah, that's the standard. So if you go and see your partner did intubation and you see this much, you see it like really buried, see just the cap of the ET tube, so to speak, at the level of the mouth, then you know what? That it's what? Right main stemmed, okay? So that's also important. So any intubation, it's your job as a medic. It's really not good care if you have not auscultated that patient before you've intubated him. You need to listen to the patient's lungs before you intubate, because you have to know what they are before, so you know what they are after you've done an intervention. And there's not much bigger interventions than intubating the patient other than cracking them, putting a chest tube in, or cutting open their chest. Or, you know, so that's a major intervention in the patient. So you want to know what their lungs were like before you intubated them, and therefore what afterwards, okay? Because if their lungs were perfectly equal bilaterally, and then it was your first intubation, and you don't hear good lung fields over the left, or just a bit diminished, but they're good on the right, you've probably right main stemmed the patient, okay? And like I said, it's not the end of the world, but it's not perfect, and we want to just make it a little bit more perfect.
So as soon as you pass the cords, then that's when you pretty much know that you're in, so you just pass the cords?
Very good question. Thank you. I didn't go over that either. So as soon as the ET tube, you see it, go past the cords, stop. And that will prevent you from right main stemming the patient. Because I think that's what happens. A lot of people are so excited or stressed. They see the cuff go past the cords, but they think they've got to keep going. And that's not. You just go past the cords. But making sure it's past the cords. You don't, it's not like just a few millimeters. Like, get it past the cords. But don't go further than that. And a lot of people just shove, and then it's going to be right main stem. So it's a very good point. So as soon as the cuff is past the cords, you're good. And if you're pulling up to the hospital, the first thing we're going to do, obviously checking ABCs and this patient's stable, we're going to get a chest x-ray. Anybody that rolls in intubated, we're already calling respiratory therapy, and we're calling x-ray to get a portable chest x-ray. And the doctor sees it within 10 minutes. So we'll know right away if the patient's right main stemmed. So really good points. Thank you.
If you suspect a right main stem and you back up ET tube, should you deflate the cuff and pull out, or
Okay.
should you?
Yeah. So in the field, I don't prefer that you as students, that I don't want you manipulating the tube in the field. Okay. So that needs to be done by a senior medic, and in the hospital, you're gonna only do it under the supervision of a physician. Okay. Because it can be backed out too far. So when we see it right main stemmed on the chest x-ray, or somebody from the field brings in a patient and I see that this is buried to here, I'm going to pull the ET tube back out some more because I know it's right main stemmed. Whether I hear decreased breath sounds or not, the tube should not be buried like that, okay? So, so it is always deflated first. So that balloon has to be deflated because you're pulling back. So you don't do any manipulations with the tube forward or backward or anteriorly or posteriorly without having the cuff deflated, okay? Or else you could hurt the inner linings of the trachea and hurt the tracheal rings. So it has to be completely deflated, and then you manipulate the tube. And the respiratory therapists in the hospital, they're the ones doing it. The physicians can do it, but usually we'll say to RT, pull back the tube 2 centimeters. It's right main stemmed, or it's at the carina, pull it back 2 more centimeters. So if anybody know the perfect place for ET tube placement on a chest x-ray, it's about 2 to 3 centimeters above the carina in the distal trachea. Okay, and that gives excellent adequate oxygenation to both right and left main stem bronchi.
Exactly where do you want to seat the tip of the Mac blade when you go in?
Okay, so you want to, as you're going from right to the middle of the tongue and sweeping, you want the tip to go down straight midline as far as you can go to reach the cords. So you're hoping the tip, whether it's the Mac blade or the Miller blade, to reach just to the level of the cords. It's just not long enough usually to go past or through the cords. So it's designed for a length like this for a reason, for adults. And so the tip is really going to be just, and there's a video that shows it better, or actually it's on a cadaver that we'll get to this afternoon, that the tip is really going to be just above the level of the cords. So you have a view of the cords hopefully staying open because the patient is unconscious or because you've paralyzed them. And so that the cords are right below the tip of your blade, and you can see it with your hand locked. And you might get tired. Like I said, I don't have much forearm musculature, but I don't care if I get tired, and I can hold my forearm like this for a long time if I have to do multiple intubations and I don't have any help. If anesthesia in the middle of the night is doing a case and I'm the only one that can intubate in the hospital, I've got to be the only one that can intubate in the hospital, okay? Or cric them. But I can't let myself get tired, because when you get tired, you get muscular fasciculations and that kind of thing. You can't let yourself do that. So you hold it locked in for as many times as you need to intubate the patient, and that you make sure that you go from the right corner of the mouth toward the middle, and that you don't obstruct your view until you get the tip of the ET tube just at the level of the cords, so you can see the tip passing through the cords. And that has to be your documentation. I visualize the ET tube passing through the cords. I say that on every patient, okay? Or if I have a poor view, then I'll be honest and I say I had a poor view of the cords, limited view, only the posterior cords, but I slid the ET tube past the posterior view that I had of the cords. So that will stand up in court. Question?
So in the pre-hospital setting, if you get a visualization of the cords and they're closed, what do you do from there?
You're not going to intubate through closed cords. So you tell your supervisor, I can't pass the tube, the cords are closed. So it's usually going to be because the patient's breathing or they're in spasmodic closure. So you're seeing them when they're breathing, they just haven't opened up their cords yet. Often if you can wait a few seconds, if they're waking up or they're awake, then their cords will open back up. But generally, you're going to be only intubating patients that are unconscious or they're done through RSI from somebody else that is trained in RSI. So generally that'll be in the emergency department more than it would be in the field.
What about anaphylaxis and swelling?
Okay, so in anaphylaxis and swelling, you're gonna, and we did talk about that. So what size tube are you guys gonna grab for anaphylaxis? Okay, you're gonna get a smaller one. Okay, so a woman you could get a 5 and a man you get a 6. So 2 sizes down, or half size, or a couple half sizes. So, and you have to be, in anaphylaxis, you really get 1 shot. Okay, like I told you about my trauma patient with the laryngeal fracture, that the trauma surgeon was standing over and said, you have 1 shot, like meaning he really didn't even want me to try. Little confidence. So you have 1 shot in trauma to the neck, you have 1 shot in anaphylaxis. Smoke inhalations, those have also been one of my most difficult intubations, where they're really swollen and soot all the way down to their cords. I've had to dig out soot I've dug out soot with the McGill forceps. I've made a tunnel and just burrowed and made a quick tunnel and took soot out and then intubated through that. Of course, I could have criked them, but I was pretty fast, so I got it that way. So there's different ways to do that. Certainly going straight to a crike one, that would be fine too. So be mindful of swelling, be mindful that there's intubations that you're only going to get 1 attempt, and the most senior person should do it. Any other questions? No? Thank you. Thank you, Devin. Thank you.